I declare this program inaugurated, and I welcome Dr. Kalpana Madam also for this program. Thank you.
Thank you, sir. We also have along with us Dr. Mohammad Kunnu, sir. Sir is past president of IAP Kerala, and he was the chairperson of Pediatric Neurology chapter of IAP Kerala, and professor in HU Department of Pediatrics, Pediatric Neurology. Sir, a few words from you, sir. Sir, out time though. Next, I invite our esteemed faculty for today, Dr. Kalpana ma'am. Ma'am is the consultant in pediatric neurology in KIMS Hospital, Trivandrum. And ma'am, I request Kalpana ma'am to start the OSCE. Ma'am, can you try sharing your screen?
Okay, yes, it is okay.
Yes, ma'am.
So first, let me thank the organizers, Dr. Sabik and Dr. Jay, for calling me. Actually, I was doing it was in short notice, and many of my slides are from the last year, and I have added few also, but just 4 or 5 days back only he has called. And
madam, just one query, ma'am. We are also doing YouTube streaming. Should we do it or should we? Because is there any?
It's okay. It's fine.
Okay. Thank you,
ma'am. So, dear Dr. Chanavas, the senior teachers, colleagues, and our dear students. So this is mainly intended for DNB students, because OSCE is one of the important parts. So we are directly going to the OSCEs. So there may be questions based on clinical history, videos, neuroimages, EEGs, drugs, etc. This is one part of part 1 of this one, and so I'll be covering some of all these, and the rest will be covered in subsequent days. So what is your diagnosis? Anyone can mention? So is there anyone who can answer these questions so that I can ask?
We'll ask them to put in the chat box, ma'am.
Okay.
Already came in the chat box, madam.
Okay.
So absent seizure.
So it is just moved on. So absent seizures. So you'll be reading that, isn't it? So describe the Eeg pattern. Anyone can describe the Eeg pattern? What is the method of activation that is shown here? That is.
One has mentioned 3 Hz spike, ma'am.
3 Hz generalized spike wave discharges, which are sudden onset as well as offset. That is the full definition, but you can say that 3 Hz spike and wave discharges, which are generalized. So 3 Hz generalized spike wave discharges. That will be the answer. And hyperventilation is the provocative procedure that has been done, and which we will do in the EEG lab also. And so the what has happened is the child has stopped hyperventilating and the child has stopped responding also. So see, he has become unresponsive and like that. So this is the absent seizure. And what are the 2 drugs of choice?
Somebody has answered ectosuximide valproate, ma'am.
Okay. So ethosuximide is the drug of choice. If that is not available, you can use sodium valproate. What is the problem with ethosuximide when we are giving? If there are any other type of seizures, it will not be controlled by ethosuximide. So previously we used only valproate. Now ethosuximide is available here. And mention 2 drugs which will aggravate the condition. Two drugs which can increase the condition, 2 anti-epileptic drugs. So they are the sodium channel blockers like carbamazepine and phenytoin. So these are the drugs that can increase the absent seizure as well as the myoclonic seizure. So carbamazepine.
359 അങ്ങനെ എന്തോണം അവരുടെ ചാർജ്. UPI ഇങ്ങനെ അവിടെ തുള്ളി കളിക്കുന്നത് എന്താന്ന് മനസ്സിലാകുന്നില്ല.
എന്താണ്? Okay, the next one, a 15-year-old girl is referred after her first seizure. The parents described the features consistent with a generalized tonic-clonic seizure. It occurred early in the morning after she had been at a party, and in between she had some blank spells, and often parents thought that she's daydreaming. And most recently, she had become clumsy, especially in the morning, tending to drop and spill things. What is your diagnosis? So many of them have written it as AME or juvenile myoclonic epilepsy. So what are the seizure types which are described? First one is generalized tonic-clonic seizures. Then what are the other seizure types? One is myoclonus, which is, and third one is atypical absence. So my generalized tonic-clonic seizures, then atypical absences and myoclonic seizures. So these are the 3 types, and mention the drug of choice in this girl. So it's a 15-year-old girl. So one has written valproate, the other has written Levipil. You should not write Levipil, you have to write the molecule, name of the molecule. What is the name of the molecule? It is levetiracetam. So Levipil is a brand name, you should not use that. So levetiracetam. Okay. So valproate is actually the drug of choice, but in a female of 15-year-old girl, we should not use it as the first choice, because valproate has important side effects like one is obesity can occur, another one is the PCODs or polycystic ovarian disease can occur. So amenorrhea can occur, and once they reach the marriageable age, then there is problem with teratogenicity also. So how long should the treatment be continued, and what is the prognosis? How long should the treatment be continued? So people have written, this Gayatri has written it is lifelong. So lifelong is the answer. Okay. So because this is a condition which is very much amenable to treatment, but treatment has to be continued very long. Often it is mentioned as lifelong, but when it is very mild and is getting with good response, sometimes after 10 years or so, we can slowly reduce and see. Sometimes they respond with a small tablet dose like 250 milligram of levetiracetam or 200 milligram of sodium valproate, like that. So the dose can be reduced, but it should not be completely stopped. So there is a probability of recurrence. So these children will have normal development as well as intelligence. Name 2 precipitating factors. Any precipitating factors you know? One is the sleep deprivation, that is correct. Second one is photosensitive. It is a photosensitive type of epilepsy. So this excessive electronics should be excessive electronics, or this flashlights be like the DJ job. All this cannot be done. This flashlight in dancers. So it is a photosensitive one. So we have discussed. So blinking lights, flashing lights, etc. So what is the diagnosis? So two types of seizures are seen, but both are different manifestation of the same condition. So it is infantile spasm. One is the flexor spasm, especially when the child is sitting, it will be easily identified. But when the child is lying down, it is a little difficult to identify. This child is having an extensor type of seizure. So always the child will be crying, and there will be a sudden extension of the upper limb that is happening here. And also often it comes in clusters. So there is sudden extension, there may be head drop, or here there is sudden flexion. And enumerate the causes. What can be the causes of West syndrome? We mention more causes. Fibrous sclerosis is mentioned, but that is one of the causes. Any other cause? We have seen infantile spasm so many times. Is it all time it is due to tuberous sclerosis? So perinatal asphyxia is one of the important things. So also many of the metabolic disorders or structural malformation, anything can happen. So, so in a child, in an infant, due to any abnormality, there can be infantile spasm, which will be between 6 months to 3 years or so. So now the term used is the epileptic spasms, because sometimes it is seen above the age of infancy also. So this is the causes can be anything, even when the lesion is on one side. In a hemimegalencephaly also at 6 months you will get the infantile spasm. So that is a common feature of any abnormality, whether it's a structural or metabolic or whatever it is, it can be infantile spasm. In pyruvate dependent seizures also you can get infantile spasm. So triad we have mentioned. Describe the Eeg pattern. Triad is developmental regression, hypsorhythmic pattern, and the epileptic spasms. Initially, it was described as mental retardation. So mental retardation, hypsorhythmic pattern of EEG, and infantile spasms. What is the EEG pattern in hypsorhythmia? It will be a background will be very high amplitude, and there will not be any. It's a chaotic background. The two sides will not be similar, and there will be high amplitude multifocal epileptiform discharges. Sometimes there may be a burst suppression also. Okay, so what is the treatment? So ACTH and Vigabatrin are the first line of treatment which can be used. And the next question is the most common neurocutaneous syndrome responsible and the drug of choice. So the most common neurocutaneous syndrome is tuberous sclerosis. And there the drug of choice is Vigabatrin. It is Vigabatrin, Batrin, Vigabatrin. The name has come from how it is a Gaba transaminase inhibitor. That is why Gabatrin has come. Gaba transaminase inhibitor. So Eeg Pattern is the most common neurocutaneous syndrome associated with this. And here the drug of choice is Eeg Pattern because it acts through the mTOR pathway. So that we have mentioned. Then 5-year-old boy with recurrent episodes of seizures during sleep, and the parents notice some throaty sounds, jerks of the angle of mouth and the right upper limb, occasionally the left upper limb. There is salivation, speech errors, and there are 3 episodes in 3 months and often during sleep only. So name the epilepsy syndrome. How will you confirm the diagnosis and the relevant findings? So what is the epilepsy syndrome that is mentioned? So many have answered Rolandic or benign Rolandic epilepsy, or we can say that benign childhood epilepsy with centrotemporal spikes. So centrotemporal spikes, benign childhood epilepsy with centrotemporal spikes. So the confirmation of diagnosis is by EEG. We will see the characteristic discharges in the central part as well as the temporal part. The age group affected is so 3 to 10 years, and has written it is 3 to 13 years. You can say 3 to 13 years is the easy one to identify, to tell. And treatment is so carbamazepine, it is responsive to all the anti-epileptics, but carbamazepine and sodium valproate is mentioned in the textbooks, and we favor sodium valproate because sometimes this epileptic discharges may increase after carbamazepine. So those who have answered, just see that it is oxcarbazepine and not oxcarbamazepine. So always students write like that. So it is oxcarbazepine. And the prognosis? The prognosis is very good. Actually, it is a age-limited disease. So by 13 years, usually 11 to 13 years, it will disappear by itself. So initially, if it is a single episode and all, there is no need for treatment. That was the previous idea. Now the idea has changed, but I think in Nelson it is mentioned like that. If it is very infrequent, there is no need for treatment. And if it is frequent, you can treat with either carbamazepine or valproate. That is what is given in Nelson. So seizures stop by itself. Bilateral spike wave discharges, which will be actuated by sleep. That is very important. If we take only the awake EEG, we will not get it. So bilateral centrotemporal spikes, which are activated by sleep. So this is a child with very frequent seizures and fever. And then next week there was abnormal behavior and child has become mute. And these are the movements that are seen. So what is the clinical finding and what is your diagnosis? What is the clinical finding? What you have seen? So the clinical finding is the orofacial dyskinesias, and there is child is very restless, and also there are dystonic movement of the upper limb also. The clear we can identify the orofacial dyskinesias. So among the autoimmune encephalitis, what it can be? It will be a NMDA receptor encephalitis. So it is an NMDA receptor encephalitis or anti-NMDA receptor encephalitis. The encephalitis is due to against the NMDA receptor. So anti-NMDA-RE. Okay. And which important finding can be picked up by CT of abdomen and pelvis? So the correct answer will be ovarian teratoma, especially when it is the pubertal age group, but it can affect younger children. There we won't see any malignancies. And what is the treatment? So this condition should be aggressively treated. So we will first line we will start IV methylprednisolone and IVIG together, and if it is not responding, we will immediately go to the rituximab and cyclophosphamide. Okay, and if it is ovarian teratoma is identified, it has to be removed. And ovarian teratoma may come even later also. So you have to keep the child under follow-up, especially if they are in the peri-pubertal age group. And so this is a 8-month-old baby with first episode of right focal seizures. There is a reddish birthmark over the left side of the forehead and face. And describe the MRI abnormality. So is it a plain MRI or is it a contrast MRI? So it is a contrast MRI, which is showing the leptomeningeal enhancement, and some of the parts we can see the tram track sign when two lines are coming parallel to each other. So this is the, and also you can note that the left side is a little smaller than the right. Sometimes this atrophy may be very prominent. And what is the most probable diagnosis people have written? That is the Sturge-Weber syndrome. And other than seizures, what are the problems these children can have? One thing that is this tram track, somebody wants to describe that. So here, actually, there is leptomeningeal means the pia-arachnoid, these regions get enhanced. This will be more prominent over the posterior part, the parietal as well as the occipital areas. The maximum will be in the occipital area, and this, when it comes through the sulci, you will see two parallel lines. This is called the tram track. Here it is not very clear, but in sometimes in CT as well as in X-ray skull, we can see the tram track a little more better. So other than seizures, what are the problems you can have? Yes, so altogether they have answered. Actually, one of the important problem is glaucoma. Then another one will be recurrent strokes or hemiparesis can occur. So the treatment is actually anti-epileptic drugs, and some people favor aspirin to prevent the episodes of stroke. If they have developed an episode of stroke, it is better to give aspirin. And when the seizures are becoming very resistant to seizures, resistant to anti-epileptic drugs, then you can do a hemispherotomy. And how will you counsel regarding the recurrence risk? It is a sporadic onset, and so the recurrence risk is negligible. Then a 10-year-old girl with recurrent episodes of fearful epigastric aura, staring, doing movements, and posturing of the right upper limb. She is on optimal dose of carbamazepine and clobazam, but is not responding to treatment. So what is the probable site of origin of seizures? So there is a fear, there is epigastric aura, doing movements, and then posturing is there. So right side is posturing and left side there can be automatisms. So the site of origin will be this. Yes, you are right. It is the left temporal region. And what does the MRI show? So left temporal, if you are more localizing, it is a medial part of the left temporal. So this is the temporal lobe. This is the medial part of the temporal lobe. Here we get the hippocampus. So you are getting hippocampal sclerosis. This part is smaller as well as it is hyperintense in T2 weighted image. So this is a hippocampal sclerosis. And what is the ideal treatment? So mesial temporal sclerosis is the word that is called MTS. So there is hippocampal or the medial part of the temporal lobe is sclerosed. And what is the ideal treatment? It is a anterior temporal lobectomy, that is the surgery. So in this condition, if the patient is not responding to 1 or 2 drugs, immediately go for surgery, because the surgery will give a very good cure rate and the patient can even be seizure free without drugs. So when these children coming with temporal lobe epilepsy, if they are resistant, it is very good if we can refer the child to a center where epilepsy surgery is being done. So 2 drugs in maximum tolerable doses in a period of 2 years or even 1 year, you can send the child. That is very, very important. So anterior temporal lobectomy, ATL, and amygdala and hippocampus is also removed, and this is a condition which has got a very good prognosis after surgery. So think about surgery also. So this is a newborn with a history of respiratory distress, needed ventilation. Mother had history of multiple abortions and stillbirth. And this is the baby and this is the mother. What is the probable clinical diagnosis? And how will you confirm the diagnosis? So one of them have answered it as congenital myotonic dystrophy. So congenital myotonic dystrophy. Sangeeta, what is your problem? So this is a congenital myotonic dystrophy. What you are seeing is a myopathic facies, and there is ptosis also, but because the child has closed the eyes, you may not be able to identify, but the myopathic facies is very clear. And when you are seeing the mother has got a alopecia is there, as well as the mother also has got a long and narrow facies, and there is some facial weakness also. So this is the characteristic facies of an adult with a myotonic dystrophy. And how will you confirm the diagnosis? How will you confirm the diagnosis? You can do the percussion myotonia in the mother. In the child, you cannot get the percussion myotonia. And the inheritance pattern is actually CTG repeats, and it is a, what is the inheritance pattern? It's a trinucleotide repeat disease. It is transmitted by what is the Mendelian inheritance? Imprint or anticipation can occur, but what is the Mendelian pattern of inheritance? It is an autosomal dominant condition. Okay, it's an autosomal dominant condition. One more important thing is that the congenital myotonic dystrophy will occur only when the mother is transmitting the disease. When the father is transmitting the disease, only the baby will have myotonic dystrophy later on, not at the time of birth, because the number of repeats may be high if the mother is transmitting the disease. That is one thing that is very peculiar to this condition. So inheritance pattern is autosomal dominant. Genetic abnormality is trinucleotide repeat, which is CTG repeats in chromosome number 90. Can you hear the sound? So this is like a winding or like starting and going in a bike. So that's a waxing and waning pattern, or you can say it as a dive bomber pattern. Sometimes this may be kept for your exam. This is the dive bomber pattern that is seen in the EMG. What is the graph shown? What are the waves and their sites of origin? So it is written there, that is the auditory evoked response or brainstem auditory evoked potential, or you can say brainstem evoked response audiometry. So it is BERA or BAEP, we can say. Brainstem auditory evoked potential or brainstem evoked response audiometry. What are the waves and their site of origin? So there are, how many waves are there? There are 5 waves, 6 and 7 are not very clear, but 5 waves are will be very clear. So the origin, that is actually we have to learn it. And what are the uses of this investigation? One is hearing impairment in children and uncooperative patients, also to detect brainstem demyelination, or in acoustic neuroma or other space occupying lesion, the BERA will be prolonged even when the hearing is not much affected. So in demyelination, as well as in space occupying lesion of auditory pathway, that is the most common use in neurology, but in infants it can be used for hearing, to assess the hearing loss. There they will do at different decibels of intensity and do it. So if it is not obtained at 30 or 35, then we'll take it as abnormal. So these are the waves. So this is, one is the auditory nerve, then the cochlear nucleus, then the superior olivary nucleus, then comes lateral lemniscus, and then the inferior colliculus. Then it reaches up to the medial geniculate body and auditory cortex. So this is the hearing pathway. So when we give a click stimuli, it reaches and we take the response from the auditory cortex, and we get all these waves. So first 5 waves are very consistent, and that is why we take the 5, but 6 and 7 are also there. So auditory nerve, cochlear nucleus, superior olivary nucleus, lateral lemniscus, and inferior colliculus that is in the midbrain. So this you have to learn by heart. So 8-month-old girl with isolated gross motor delay. The child is able to sit with support. The child is born of consanguineous parent. There is death of elder sibling at 18 months. The child has hypotonia and decreased reflexes. Hepatomegaly is also found. So what is the diagnosis? What test you will order, and it is the deficient enzyme. So it is Pompey's disease. The doll-like facies is important. Actually, I have given too many clues. So you can even be asked like, this is a floppy baby born to consanguineous parents, and the picture can be put so that the doll-like facies can be identified. And what are the tests that you will order? So someone has answered it as echo. Before echo, what other investigation you will do? Is an ECG. Before that, we will do an X-ray test also. So X-ray test and ECG, because it will give findings for the cardiomegaly, and ECG will show you a short PR interval will be seen. Short PR interval and large amplitude waves will be seen, and echo will be confirmative. And what is the deficient enzyme? It's not isomaltase, some other maltase. So it is acid maltase or alpha glucosidase enzyme. So what is the treatment? So enzyme replacement therapy, we have the enzyme that is available, that is called myozyme. And genetic test also we can do. It is an autosomal recessive condition, so gene test also can be done. This picture is not very clear. So 5-month-old baby with isolated gross motor delay, there is. So you may be able to see somewhat and hypotonia with absent reflexes. So this will be a SMA. What is the type? What is the type of SMA here? So you can see the tongue fasciculations or fibrillation, you can say. And what is the mode of inheritance is autosomal recessive. So we have 3 or 4 types of SMA. SMA type 1, 2, and 3. Type 1 is actually starts from less than 6 months. Type 2, they are not sitting. Then type 2 is 6 months to 18 months. And type 3 is after 18 months. So the first one is non-sitter, second is sitter, and the third type 3 can walk. In adult, there is a type 4 also. So what is the deficient gene? It is SMN gene. And actually we have 2 SMN genes. One is the SMN1 and second is the SMN2. SMN1 is the one that causes the disease, and SMN2, the number of copies is protective. So in type 1 SMA, we have only 1 or 2 copies of SMN2. In type 2, we will have 3 or 4 copies, and type 3, there will be more than 3 or 4 or 5. So in type 1 will be the most severe, and death will occur by 2 years. What are the new drugs? They are written, nusinersen, risdiplam, risdiplam and Zolgensma. So what are these drugs? Nusinersen acts by enhancing the production of SMN2 by an antisense oligonucleotide. Risdiplam also acts by that. The difference is nusinersen has to be given intrathecally because it does not pass the blood-brain barrier. But risdiplam is an oral drug. You can give it as a solution. And Zolgensma is the genetic treatment. Here, the adeno-associated viral vector carries the SMN gene and then it enters the cell. So here, only a single dose is required. But the response is not very it is not like a miracle cure. There will be improvement, but mildly affected type 3, type 2 and type 3 can have a better response. For type 1 to have a better response, you have to start it immediately after birth or within 2 to 3 weeks. So now many countries are screening for SMA and they are starting treatment immediately after birth. They have very good response. What is that? So episodes of stiffening of legs and jerking with loud sounds, bathing, etc. And when we touch the nose or anywhere near this area, so we are getting a startle response. And what is the diagnosis? It is hyperexplexia. How can you avoid these episodes? How can we avoid the episodes? By the Vigevano maneuver. What is the Vigevano maneuver? This is by suddenly flexing the neck. Because these children will get very stiff in infancy and even death can occur. It can produce a sudden infant death syndrome. So we have to teach the parent to suddenly flex the neck so that this can be avoided. And what is the inheritance? What is the inheritance? It is, what is the inheritance? So any other response other than autosomal recessive? It is actually autosomal dominant. So when the mother or father is affected, the child may be affected. And what is the abnormality that is seen? Chemical or by neurotransmitter wise, what is the problem? It is not GABA, so it is glycine. So glycine receptor abnormality. So what is the treatment? Treatment is clonazepam. It responds very well to clonazepam. Otherwise, whatever anti-epileptic we are giving, the child will not respond. And after 2 to 3 years, the number of episodes will come down and there will be just a startle, but the person will not fall. So you have to ask directly whether any one of the members have got increased startle in response to sound. That is very, very important. And also these children will have stiffening and on bathing, there will be startle. So it is very difficult to bathe these children. So abnormality in the glycine receptors. This one, everyone will be knowing this because this is very commonly asked also. So what is the clinical sign? That is opsoclonus. It's described as chaotic multidirectional movements without an intersaccadic interval. There is no interval between the saccades and it is multidirectional and chaotic. It is not like it's a horizontal or vertical or rotary like that, but it comes as and when is required. So it is a chaotic as well as multi-directional movement without an intersaccadic interval. What are the investigations? So name the disease associated with it. It is neuroblastoma. Is it seen in all of the cases? So it is seen in about 20 to 30% of the cases. Others, it can come as a post-viral demyelination. So what is the investigation that will, so what are the other associated features other than opsoclonus? Somebody has written it as OMA. What is OMA? It is opsoclonus, myoclonus, and ataxia. So there is ataxia, there is myoclonus of the upper limb, and opsoclonus. So opsoclonus, myoclonus, ataxia. What are the name the investigations for the disease? That is for the neuroblastoma. What are the investigations that you will do? So we will do an ultrasonogram of which part of abdomen then. So ultrasonogram of abdomen is done, but many a times it can be in the thoracic region. So we may have to do a CT or MRI of the abdomen as well as thorax. And the next one will be the neurotransmitter, that is the metabolite VMA or the neuron specific enolase. But the number of the percentage of yield will be very less. Any other PET CT is the other investigation. Another scan that can be used. Another scan which will be useful other than the PET CT. Whole body scan, it's a radioactive. So it is a MIBG scan. Okay, MIBG scan that is specific for neuroblastoma. Then PET scan, then CT or MRI of the chest and abdomen. And what are the treatment modalities? So the treatment modalities, what is the drug of choice that is mentioned? Before IVIG? So steroids, but the ACTH is the first drug of first choice. IV methylprednisolone is also very useful, but ACTH is the drug of first choice that is mentioned in a textbook also. So ACTH is the drug of first choice. Then you can use IVIG. Also rituximab, dexamethasone also can be used after ACTH. Sometimes you may have to continue it for long periods because there is chance for recurrence. And associated condition is neuroblastoma. So you have to treat the neuroblastoma also. So that also has to be mentioned along with the immunomodulators. So ACTH, IVIG, rituximab, dexamethasone, all can be used. Along with that, we have to do the treatment for neuroblastoma also. But just the treatment of neuroblastoma will not cure this condition also. So this is not a very easy condition. There is a chance for recurrence, and later on children can have behavioral abnormalities also. So you have to treat this very aggressively. So we have mentioned that. So neuroblastoma in 25%, USS abdomen, CT abdomen, MIBG, PET, myoclonus and ataxia, removal of tumor, ICTH, dexamethasone, IVIG, and rituximab. Describe the MRI abnormality and what is the most probable diagnosis. What is the abnormality? You can look at the picture B and other pictures. This is the SWI picture. This is the diffusion. So this picture, which is the area that is involved? Which is the area that is involved? Someone has put the diagnosis, but what is this structure? This is the thalamus. So the thalamus will be very much swollen and enlarged, and there is a central part, that will be diffusion restriction, as well as there can be hemorrhage. In SWI, the black color indicates hemorrhage. So this is a double donut sign, and that is seen in dengue encephalitis. Also in H1N1 you can see. In COVID also it has been described, and one person is written as neck or acute necrotizing encephalopathy in childhood. That is also possible, but often the basal ganglia also may be ignored. So we can see, write this as the double donut sign of dengue encephalitis, H1N1, post-COVID encephalitis, like that, and acute necrotizing encephalopathy of childhood, that is a neck. So we have written the thing. If this question comes like thrombocytopenia, flushing, and behavioral changes, then you can directly write it as dengue encephalitis. Then describe the imaging finding and the probable diagnosis. Enumerate the risk factors and what are the important sequelae. Any idea? So one person has written encephalomalacia is at what parts? This is not HSV. This is a newborn. It's not newborn. A child who has suffered from some perinatal problems. So this is actually a hypoglycemic sequelae. There is gliosis and cystic changes with atrophy over the occipital region and somewhat in the parieto-occipital region. So this is the medial occipital as well as the parieto-occipital region is affected. Most common is causes hypoglycemia. And what are the risk factors for hypoglycemia? So preterm sepsis, yes. Rather than preterm and sepsis, you have to tell IgDM, SDA baby, like that. Preterm also we can say, and some of the neonatal syndromes which produce hypoglycemia. IUDR is very, very important. For all these conditions, you have to see their blood sugar level regularly. Otherwise, this will happen. So you can be baby friendly, but at the same time, you have to see that the child is feeding and child is active. If it is a very active crying baby, you can be happy. But if this is a very encephalopathic child, or if the child is very irritable and not at all feeding, you have to be careful. So what are the important sequelae? Is cortical blindness is one. Then visual field defects can occur. What else? So the parieto-occipital area is the area for attention. So what will happen? You will have attention deficit hyperactivity disorders. Then seizures are very, very important. Seizures are not occasional. Seizures are very, very frequent and often intractable. And even surgery cannot be done in these children because it is in the medial occipital region. So it is a intractable seizures, and squint also will occur. So these children also can present with West syndrome. So this hypoglycemic brain injury is very, very important. And somebody has asked for the 14th slide answer. So there is a T1 hypo and T2 hyperintensity in the bilateral thalamus with swelling. And there is this is the diffusion weighted, and this is the ADC map. Diffusion weighted, it is white, and in the ADC, it is black. That means there is diffusion restriction, which indicates cytotoxic edema. And this one is the SWI image, which shows the central hemorrhage. So this may not be asked, this much may not be asked for you. I have written it full, that's all. So you may be shown this double donut sign or something like that only. So the next, this one we have discussed. So there is atrophy and gliosis, so the parieto-occipital and the medial occipital area. The probable diagnosis is neonatal hypoglycemia. And this HIE children also are prone for hypoglycemia. So sometimes it may be a combined injury. HIE, because of the HIV, child is not feeding and child will get hypoglycemia. Then SDA, IGDM, LGA babies, HIE babies, like that, seizures, visual impairment, global developmental delay, intractable seizures. So what is this? So what is this? Describe the finding. First, you have to say in which view, what is this? So this is an cranial ultrasound scan. And it shows, this is the coronal view. And it is showing this ventricle, you can see clearly. This ventricle is filled with blood and there is blood in the parenchymal areas. So what is the grade of the hemorrhage? It is grade 4. So it is a periventricular, intraventricular hemorrhage. So the different grading, the first one will be the caudothalamic groove. Second one will be, it will enter into the ventricle, but there is no ventricular dilatation. Third part, grade 3 will be, there will be hydrocephalus, but there won't be any parenchymal hemorrhage. When there is parenchymal hemorrhage, it becomes grade 4. Okay. Then name 2 complications. One is hydrocephalus, as you have mentioned. The second one will be, this bleeding will result in a porencephalic cyst. So there can be hydrocephalus and there will be a porencephalic cyst, which will later result in a weakness as well as seizure. So porencephalic cyst and hydrocephalus are the 2 answers. Or if we write seizures also, it is okay. But these are the 2 complications that you can see. So hydrocephalus, porencephalic cyst, seizures, and hemiparesis. So what is the abnormality that is marked? This is a picture from Nelson. So what is this? Over the basal ganglia, you're seeing bright spots. This is T2 weighted image. The calcification is not like that. In T2 weighted image, the calcification will be hypo. So it will be black in color. This one is white in color. And the T1 is normal. And they read the other history. What is the natural history? In which condition these changes are seen? And what else? What are the? So basal ganglia calcification, if it is a CT, then you can say this is an MRI where you are seeing white lesion, discrete lesions in T2 weighted image, but in T1 weighted image, there is nothing. And even so, this is called unidentified bright objects. So UBO, unidentified bright object. This is seen in which condition? UBOs, anybody has seen? So it is seen in neurofibromatosis. That is very good. So this is seen in neurofibromatosis. And what is the natural history of these lesions? So this is seen when we take it at 5 years or 10 years or so. But when they grow older, this will disappear. These are certain hamartomatous lesions. And they will disappear as the person matures. So it will be seen in neurofibromatosis type 1. And what are the neurological complications that you can see in this condition, that is neurofibromatosis? So these UBOs are not having much clinical significance. This is one finding by which we can say that this is a neurofibromatosis type 1. So what are the complications? What are the features? Neurological complications of NF1? Anyone? So you can get optic glioma. Grishma, very good. So any other complications in neurofibroma when you are getting a neurofibroma? So sphenoid hyperplasia will occur, but that will not produce any neurologic complications. What are the neurologic problems that these children can get? Optic glioma is one. Visual impairment. Stroke you can get is a cause of moya. Then these children can have attention deficit hyperactive disorder. That is very, very important. Seizures, in a small percentage of cases, you can have seizures. They can have, some will have autistic features can be there. Then any type of glioma can occur. So it can be brainstem glioma, or it can be a thalamic glioma, or gliomas in the supratentorial compartment. So gliomas at any place, optic and optochiasmatic are the most common, but thalamic gliomas are also common. And spinal cord tumors, spinal cord neurofibromas, very, very important. So these are the neurologic findings. In skin, you can get neurofibroma, you can get plexiform neurofibroma, which can get malignant neurofibrosarcoma. So very findings are there. The finding in the eye is the leash nodule. So identify the findings. This is also a picture from Nelson. So it is fibrous sclerosis. What are the findings that is shown? The first one written as C. Previous one answer. Okay. So what is that lesion that is shown here in C? This one, the skin lesion, what is that? It is not the commonest ash leaf macule, but this is a different one. So this is a, Dr. Vikas has answered, it's a shag green patch. So this is a shag green patch, and this is the leiomyomatosis of the lung and cardiac rhabdomyoma. So what will happen to this rhabdomyoma? Rhabdomyoma is the finding that will be seen in the early stages. That is, even before birth you may get, or after birth we'll see. After that, what will happen? So is it a symptomatic one? It can sometimes produce a heart block. But after, what will be the natural history? After 2 years, it may disappear. So rhabdomyoma is one that disappears. And what about leiomyomatosis? When does it appear? This appears later, that is in puberty or after that. So leiomyomatosis and angiomyolipoma will develop later. And that are the reasons for death because of the torrential bleeding. So this angiomyolipoma and leiomyomatosis, lymphangioleiomyomatosis, isn't it? So these two can produce sudden death. So you have to be very careful. And actually, it is more important than the neurological manifestation. So when these children become big, or when they reach puberty or post-pubertal age, you have to look for this angiomyolipoma, which may remain benign, and then there will be sudden hemorrhage or hematuria, and lungs also there can be hemorrhage. So you should be very careful. And the kidneys, you may need sometimes kidney transplantation. So it has to be identified early and treated. What is the drug that is useful and the mechanism of action? So everolimus cancer. So it is an mTOR inhibitor. So So the shag green patch is important. You have to see this. So shag green patch and lymphangioliomyomatosis and rhabdomyoma heart, TS, everolimus, and it is an mTOR inhibitor. Okay. This is the question that I have to ask. So this, somebody wanted to see this. So what is the abnormality? Is unidentified bright objects in the basal ganglia in T2 weighted scan. It disappears by 30 years. The diagnosis is neurofibromatosis type 1. You can have ADHD. You can have learning disabilities. You can have seizures in about 8 to 10%. You can have gliomas, which can be optic nerve glioma, optic chiasmatic glioma. Sometimes you can get precocious puberty. Then you can have gliomas in the thalamus and the brainstem, and neurofibromas affecting the spinal cord. So that is it. Then an infant presented with acute onset of dystonia, encephalopathy, and ophthalmoplegia. The parents are consanguineous. There is history of death of elder sibling with recurrent episodes of dystonia and ophthalmoplegia. But this child improved completely with some oral medication. What is your diagnosis and what is the treatment given? So this child presented very acutely with dystonia, and there is florid MRI findings that you have to see. So the Segava syndrome does not have any MRI findings. It will be normal MRI only, and it will be a progressive condition, and the feature will be diurnal fluctuation. This is sudden acute or subacute onset. Sorry. Acute and subacute onset, and it responds very well to treatment with oral drugs, or you can say it responds to some vitamins. So what can it be? So this picture is also from Nelson. That is why I have put this. This is not very common condition, but we had cases. So there is hyperintensity of the basal ganglia, that is the caudate nucleus, the putamen. Then there is bilateral thalamic nuclei, and you can see in the cortex and also in the cerebellum. So these are the regions that are involved, and the diagnosis is biotin responsive basal ganglia disease. And what is the treatment given? That is biotin plus thymine. So this condition, where it is large doses of like 5 to 10 milligram per kg of biotin is given, and it will give very good response, and this abnormalities also will disappear. So this is a very eminently treatable condition. If the parents, this history of death and consanguinity were not there, then other possibilities may be like an ADAM, because the basal ganglia is affected, as well as the brain white matter and some gray matter is also affected. Cerebellum is also affected, but here the lesions are very symmetrical. Whenever the lesions are symmetrical, think of some metabolic abnormalities. So this is a biotin and thymine responsive basal ganglia disease. This picture is there in Nelson, so there is a possibility that it can be asked in the exam. So this is the gene SLC 1983. Biotin responsive basal ganglia disease, we call it as BBGD, and treated with biotin and thymine, and the gene is SLC 1983. So one more, this is the this is the last slide actually. This is there is no answer here. What I have put is this is the mechanism of action of anti-epileptic drugs. Our students were telling that this was very commonly asked. So this is the picture that is given in Nelson. So you have to see all these, what are the things. One is the voltage gated sodium channel that will be seen presynaptically. So this is the presynaptic area, the terminal end plate, and this will be the postsynaptic region or the muscle membrane. So here in presynaptically, it acts on the sodium channel. So sodium channel blockers, phenytoin, carbamazepine, oxcarbazepine, see the spelling, eslicarbazepine, lamotrigine, lacosamide. Lacosamide is a sodium channel blocker which acts on the slow sodium pathway. So it acts on the slow sodium channel. So it slowly closes very slowly. So only this slow channel is blocked. So its uses, the other side effects will not be there. So these are the sodium channel blockers which should not be used in absence seizure and myoclonic seizures, but these are the drugs of choice in focal seizures. So whenever the lesion is seizure is focal, you give the sodium channel blockers. When it is absence or myoclonic, you should not give this. So this is the sodium channel blockers. Then this is a special one, that is the synaptic vesicle 2A protein, and from these vesicles the neurotransmitter will be released. So here SV2A blocker is levetiracetam. So it has got a different mechanism of action. So levetiracetam often has SV2A, synaptic vesicle type 2A protein. And another one that everybody is interested is the potassium channel blocker, that is retiagabin. This drug is said to be of use in the benign infantile and neonatal infantile convulsions. But this drug is very toxic, so it has been withdrawn from the market. There is another drug, that is esogabin is there. Then the GABA, we have GABA in the presynaptic area and GABA channel in the postsynaptic area. The presynaptic area, the gabapentin and pregabalin acts, and GABA reuptake inhibitor is tiagabin, and GABA transaminase inhibitor is your vigabatrin. So GABA reuptake inhibitor is tiagabin, and then GABA blockers, and also it blocks the calcium channel, that is gabapentin and pregabalin. And the postsynaptic calcium channel blocker is ethosuximide. This is very important. Retiagabin affect both presynaptic and postsynaptic potassium channel. Okay. So then we have two receptors. One is the GABA receptor, another is the glutamate or the excitatory glutamate receptor. And this GABA receptor is blocked by barbiturates, benzodiazepine. Also valproate is acting here. Valproate also acts in the calcium channel also. Here sodium valproate is not shown. Also it has got some action in the sodium channel. Okay. So this is the GABA transmitter and the chloride channel, GABA receptor. So benzodiazepine and barbiturates act at two different parts of this channel. Then ethosuximide act on the calcium channel. Here it is acting on the calcium channel, and it has got an action in the this excitatory transmitter, that is the NMDA AMPA receptor. Also it has got an action, and the drug that is acting on AMPA receptor is perampanel. That is the newer drug that has come. Perampanel is acting on the AMPA receptors. So the word has come like that, perampanel. So AMPA is there. So these are the channels and the drugs acting on that. This has been asked many times in OSCE. So you have to learn this, and you have to at least see it in the day before examination. Okay, that's all. Thank you all for the listening. Any doubts or anything you can ask. There are so many other questions are also there. I have put that only this much. Okay,
Thank you. Thank you, ma'am,
can anyone
for the wonderful session.
make her unmute?
Participants can unmute themselves and ask if you have any doubts.
Can you unmute Priya? One has raised the hand.
Yes, ma'am. Priya, you can unmute yourself. I have put the option of
Or
unmuting.
unmute all. Somebody wants to say something, they can say.
And I request all the participants to start practicing, like when my ma'am is doing the questions, start practicing by answering each questions. Then only you'll gain that speed of answering. That is very important, Oski, right now, ma'am?
If there are no questions or comments, I think we can stop.
Yes, somebody has asked about initial slides, so that will be available in YouTube of IAP Kozhikode. So all these, all classes of ma'am is being recorded, so that is easily available. And it has been a wonderful session, ma'am.
Any questions?
I think nobody's asking any questions.
So it is difficult to show the earlier slides because I have to tell again and again.
Yes, ma'am. Actually, it's available on YouTube, so they
Live
can.
streamed, it seems.
Yes, sir. It's actually saved in YouTube. Just go to IAP Kozhikode. They'll get it.
Jay, can you finish it up?
Yes, ma'am. On behalf of IAP Kozhikode and IAP Kerala, I thank Dr. Kalpana ma'am for that wonderful session. You covered almost all the aspects of neurology. It's
You're
very
not
vast.
audible, it seems.
Can you hear me now, ma'am?
You are audible. You are audible.
Yes, ma'am. So I think this is just a starting of neurology. So we expect more classes from Kalpana ma'am in neurology in further part of neurology also, ma'am. And on behalf of IAP Kozhikode and IAP Kerala, I once again thank Kalpana ma'am. Shana, sir, do you want to add something, sir?
Nothing. You wind up, please.
Yes, sir. Thank you, ma'am, and thank you all the participants for the wonderful participation. Thank you, ma'am.
Okay, bye.
Good night, ma'am.
Good night, ma'am. I was on duty. Thank you, ma'am, for coming in the short notice.
Sabik, you can stop the.
Okay.